And also in front of the scapula, there is another bone which helps in their movement of their superior extremity, means the wings. And human, gradually we evolves, but in human, this flying is not much used or not much required. So that the function of this bone is not much in our body. They gradually, evolutionary, gradually small in some higher vertebrates, then birds, then ultimately in human, it becomes very small. And then the nature thinks that why we give another bone. Another bone means another burden to the body. One thing you must remember, miser mane ki? What is the meaning of miser? Huh? Ki? Shylock the miser mane ki? Huh? But miser? Kripon, Kipte. Nature is the greatest miser. Er moto, such a miser is not seen throughout the world, but not like a Shylock or something. When things are required, they give. When things they don't require, they don't give. Suppose we are full of, our stomach is full. Still, if we find a chicken roll, we want to take it. There is a need. So I take it by spending money. But nature thinks, no, this is not good. The most precious thing or currency in our whole kingdom is not the money, is the ATP, adenosine triphosphate, which gives energy to doing anything in our body. And nature, our body produces this ATP, adenosine triphosphate, by a very complicated process which requires so many input in our body. So nature do not waste this ATP for nothing. Whenever they require, they give. When they require, they don't give. For example, sesamoid bone. Every bone has got a perichondrium, which is covered by a membrane which gives it protection, fibrous layer, and also gives the nutrition, blood vessels coming through the bone through the periosteum, and also gives necessary osteogenic layer. I am not going to detail. At least periosteum gives protection and nutrition. But in sesamoid bone, which is within the tendon, this is the sesamoid bone, this is the tendon. Why the protection is needed now? Because it is already covered by the tendon, the toughest substance in the body. And also, they can take nutrition from the surrounding blood vessels which supply the muscles by diffusion. So, sesamoid bone has got no periosteum. So, one of the criteria of the sesamoid bone, no periosteum. It is the reason. Not needed. So, nature don't give it. Similarly, this bone is required in bird, but ultimately, this is not required in human. So, nature, it gets small, and nature doesn't allow to give another bone, another burden, another periosteum, another blood supply, another thing. So that these bones gradually become, by evolution say, attached to the main bone scapula, and it is the coracoid process. So atavistic epiphysis is epiphysis, which in lower animals it is a separate bone, but in human it is been attached to a nearby bone. As it develops from a after birth from its ossification center, it is a secondary center of ossification, so we call it epiphysis, secondary epiphysis, and it is the example of atavistic epiphysis. This is the coracoid process of the scapula. কি গো স্ক্যাপুলাটা কোথায়? না ওটা তো লাগবে আজকে, এক্ষুনি লাগবে। Next is the aberrant epiphysis. Aberrant epiphysis is what? Normally, for example, this is the metacarpal bone, long bone, 5 metacarpals from thumb. It is the thumb 2, 3, 4, 5. It is an example of what type of bone? Miniature long bone or short long bone. Short long bone. And the difference of the long bone and short long bones are one. In long bone there are two secondary epiphysis, one on or more than two epiphysis, one on either end. But in long short bones there is a primary center of ossification here and a secondary center of ossification single, not any here, only one end. Normally, secondary center of ossification, and we call it this metacarpal, this is the head, this is the shaft, this is the base. This is the head, it is the shaft, it is the base of the metacarpal. Head, shaft, base. Normally in 4 digits, the secondary center of ossification appears here in the head. But normally, in case of a thumb, the secondary center of appears in the base. This is the normal. This is the normal. It is the thumb is an exception with the other abnormal. So it is the normal. But sometimes in some few persons, secondary center of ossification also appear in case of a thumb, suppose here. So it is not a normal. And gradually it become attached to this here. And this abnormal thing, extra epiphysis, we call aberrant epiphysis. Aberrant epiphysis. Aberrant epiphysis. Aberrant epiphysis. Finished. Types of epiphysis finished. Next, we are going to the laws of ossification. শেষ করতে হবে quickly. Laws of ossification, especially in a long bone. First law of ossification is that primary center appears before birth, secondary center appears after birth, except few, as one. The primary center of the some of the carpa mainly appears after birth. আমি আসবো পরে ওটা গেল এরপরে যেটা আসল in case of a secondary center of epiphysis, which epiphysis appears first, which will it unite to the shaft last. This is the most important law, except fibula. Suppose, for example, radius, what you seen? The lower end first appears first, 2 years, and here it is appear 5 years. Secondary center of lower end appears first in 2 years, and secondary center appears of the head of the radius later, 5 years. According to this law, who will unite with the shaft first? Yeah, right, this. So it unites with 18 years, it unites with 20 years. It is the normal law, except fibula. Next, growing end of long bone. That already I have described. Nitrant artery is direction is either on one end of the bone. And I have already told you that this zone will gives maximum blood vessels nutrition, and it will appears, it will joins with the diaphysis fast. Agi bolechi, this gets more nutrition, this end gets more nutrition, this end gets less nutrition. So gets more nutrition, more maturity, quickly matured and quickly joins. These become mature late and joins with this late. So what's happened? Suppose this joins with this shaft first, then the growth of this end will stop. But final, join korega, they will not develop. And till that, but this is not joined, till the cartilage is there, still the plate of cartilage is there. So this can grow. This can grow. After 2 or 3 years, for example, radius, this ultimately joins with and the growth stop. So we call this is the growing end of the bone. It is the growing end of the bone. So if there is a damage to the growing end of the bone, the bones will not develop and it will be shortened. So growing end of the bone law ki bolche is opposite to the direction of the nutrient artery. Growing end of the bone is opposite, edike direction, growing end eta is opposite to the direction of the nutrient artery. Clear? And third point, already I have described, if there is an pressure and traction epiphysis, pressure epiphysis will appear first. And these are the laws of ossification. So I complete the bone general anatomy and I quickly go to the shoulder joint. One of the most important joint, not only in the clinical point of view, but also to the important for your examination point of view. Shoulder joint আছে দেখো, back to back. Shoulder joint. How to read a joint? How to read a joint? Any joint we read in the following headings so that no point is missed. Number 1, ভালো করে শোনো এটা, type of joint. Number 2, articulating surfaces. Number 3, ligaments of the joint. Number 4, relations of the joint. Number 5, movements of the joint and muscles producing the movements. Next, last, applied anatomy, clinical anatomy. So with this heading, we will read the shoulder joint. There are different types of joint in your body, synovial joint. Before going to the joints of the shoulder joint, just some introduction. There is a term shoulder joint and a shoulder girdle. Two are different. Shoulder joint is this. This is the shoulder joint. And this is the shoulder girdle, consisting of clavicle, scapula and two joints, sternoclavicular joint and acromioclavicular joint. This is the acromion process of the scapula. This is the coracoid process. This is the scapula. This is the head of the humerus, greater tubercle, lesser tubercle. It is the intertubercular sulcus. So this is the shoulder girdle, consisting of two joints, sternoclavicular joint, sternum with the clavicle, and acromioclavicular joint, acromion process of the scapula and the clavicle. This is the shoulder girdle and this is the shoulder joint. Types of, ebare amra chole jacchi. And there is another word, sorry, etao bole nei. Coracoacromial arch. Coracoacromial arch. This is the coracoid process. This is the acromial process of the scapula. Coracoid process, acromial process. And in living condition, in recent state means when the person is living. In recent state, there is a ligament from the tip of the coracoid process to the tip of the acromion to the lateral border of the coracoid process. এই আঙ্গুলটা হচ্ছে একটা ligament, tough fibrous band, a ligament. Which hangs over the superior aspect of the head of the humerus. ঠিক superior aspect of the head এর উপরে রয়েছে as an arch. So we call it coracoacromial arch. Consists of the acromion process, coracoid process and a ligament joining the coracoid process and the acromion process. We call the coracoacromial ligament. It is an arch over the shoulder joint. Just underneath it, there is an bursa. I have already told you what is bursa. Bursa means a fluid-filled structure like a balloon containing fluid. Whenever there is a chance of friction of tendon and muscles on the bone, to minimize this friction, to prevent the damage of these muscle fibers or tendon fibers, nature gives a fluid-filled structure called bursa, plural bursae. This bursa is just present between the muscle or tendons and the bone, so that friction, whenever there is a movement, the ligaments and the muscles are saved by friction directly against the bone. Some bursa may communicate with the joint cavity. A few bursa will communicate with the joint cavity and few bursae not. So just underneath it, there is an bursa, and just underneath the bursa, just over the capsule of the shoulder joint, there is a muscle known as the supraspinatus muscle. Very important. Supraspinatus muscle. Another name of shoulder joint is the glenohumeral joint. Why? Because this is known as the glenoid cavity and this is the humerus. So it is a glenohumeral joint. Type, synovial joint. Subtype, multiaxial ball and socket joint. Ball and it is the socket. Multiaxial, It moves in different axes. So many axes it can move. So we call it multi-axial. So ball and socket type of synovial joint, multi-axial. Next, articulating surface. আগেই বলেছি টাইপের পরে আর্টিকুলেটিং সারফেস কি কি আর্টিকুলেটিং সারফেস আছে medial, it is the medial side, it is the lateral side. Medially the articulating surface is the glenoid fossa or glenoid fossa of the, এটাকে বলে glenoid fossa of the scapula, which is covered in recent state in living condition by a cartilage, plates of smooth cartilage, hyaline type of cartilage, so that there is a smooth movement. If directly bone is there, there will be constant irritation and movement will be not smooth. Similarly, laterally, the articulating surface is the head of the humerus. Head of the humerus, which is in recent state, in living condition, it is covered by a hyaline cartilage. So that cartilage on cartilage, movement is very smooth. Right? What is the peculiarity? There is a multi-axial socket joint, multi-axial ball and socket joint is present in our body, that is the hip joint. What is the main difference between the hip joint and the shoulder joint? Hip joint is more stable, shokto, but movement is restricted, not well freedom. But shoulder joint, so many movement, wide range of movement, but the stability is minimum. Because why stability is minimum? Glenoid fossa is not so deeply concave than the hip bone socket. It is more or less slightly concave, so that there is a chance of slipping. Plus, the area of the glenoid fossa is less than the area of the whole of the ball of the humerus. So only any position of the shoulder joint, whether it is partly flexed, extended, abduction, only 1/3 of this area comes in contact with the glenoid fossa. দেখো বাকিটা বাইরেই বেরিয়ে আছে. So there is an every chance of slippage, but it has been prevented by the some of the factors. I will come later on when we'll go to the ligaments and then. So articulating surface is finished. Next, first ligaments is the capsule. Capsule I have already give you. It is covered whole of the joint. It is totally covering the joint. বুঝতে পারছো? So we cannot see the joint cavity, either we cut the capsule. And capsule has got attachment medially to the scapula and also laterally to the humerus. Capsule though it is a membrane like structure, but we call it ligament. Capsular ligament, loosely capsule. The capsule is medially attached. It is the capsule, tough fibrous structure. It is attached medially to the scapula and laterally to the humerus. কোথায় attach করছে? Medially. Medially it is attached around the margin of the glenoid fossa. এইখানটা attach করে আছে. Around the margin of the glenoid fossa. Except inferiorly, there is in some margin টা একটু ঝুলে থাকে, অত ডিটেইলস জানার দেখি। And laterally, already you know, humerus has got how many types of neck? Anatomical neck, surgical neck, and morphological neck. This is the anatomical neck. Laterally, the capsule is attached to the anatomical neck. Except inferiorly, this is slightly goes below and attached to the surgical neck. It is attached to the anatomical neck. এখানটায় বোঝাই। It is a scapula, coracoid process, greater tubercle, আর এদিকে পরে আসছি। So, color-ই নেই। Medially attached to the margin of the glenoid cavity and laterally attached to the anatomical neck, except inferiorly it is slightly hangs on the inferior aspect, and it is the surgical neck. So it is the inferior, it is the superior, it is the medial, it is the lateral side. So inferiorly the attachment of the capsule is slightly below the anatomical neck, almost up to the surgical neck, again goes to the humerus. This is the capsule. Number 2, most important question for oral. In the capsule, there are some openings, usually 2. দুটো হোল রয়েছে, ফুটো রয়েছে। Anteriorly, there is an opening. কি ওপেনিং কি হয় আমি পরে আসছি। And here, এটা ভুলে গেছি একটু, এইখানে দেবে। There is an opening here, laterally. There is an opening here. This opening is very important. এটা ভালো করে শোনো। This opening is very important. Why? Because this is the scapula. তাই রাখলাম। Oh, you know this is the পড়েছো কি scapula? Supraglenoid tubercle. From this supraglenoid tubercle, which muscle arises? Short, very good. Short head of biceps. नहीं, long head of biceps. भूल बोललाम. Long head of biceps. Short head तो एकान देखे. Long head of biceps. गेलो? Long head of biceps. Which is intracapsular. Usually muscles arises from the outside of the capsule, more or less all the muscles. But here this muscle takes origin from the inside of the capsule. Inside of the capsule. But their insertion must comes out through the capsule. Otherwise, how do they come out and go into action? So, there must be an opening in the capsule. So, this is the biceps muscle tendon. It comes out through this opening and lodge in the intertubercular sulcus. And ultimately, the biceps muscle is here. The main biceps muscle is outside the capsule, but the origin is inside the capsule. So this muscle must comes out through an opening of the capsule. Otherwise, how do they come out? So the opening is here. And through this opening, the biceps tendon comes out and it becomes muscles here. So there is an opening in the capsule. Similarly, posteriorly there is also opening in the capsule. Key capsule opening হয় পরে আসছে। তাহলে এইটা গেল ক্যাপসুল সম্বন্ধে শেষ। Next, synovial membrane. Synovial membrane. What is it? Every capsule, synovial joint, if it is the capsule, suppose it is the capsule, inside it is lining by a glistening membrane. Another membrane is there inside. ব্যাপারটা কি? ছবি আঁকি, কারণ দুটো রুমাল নেই আমার। If it is the capsule, inside there is another capsular-like membrane, which we call synovial membrane, which secretes synovial fluid within the joint cavity. Every joint cavity has got a small fluid inside the joint cavity, which we call synovial fluid. Synovial joint, every synovial joint has got a fluid, very minimum amount of fluid within the joint cavity. Within, we call synovial fluid. How do they come? Through the secretion, এখানে cell রয়েছে. These cells secrete synovial fluid. So we call this inside membrane the synovial membrane. This synovial membrane covering the inside of the capsule, and when they comes out, they give a sleeve like sheath around the biceps tendon, like this. This is the biceps tendon, and synovial membrane comes through this opening. It lining the opening of this synovial membrane, lining this, and ultimately gives a covering of the biceps tendon as a sleeve, এরকম. So synovial membrane comes out from the joint cavity. Similarly, anteriorly, synovial membrane comes out from the capsular boundary of the joint cavity and form a bursa. We call subscapular bursa. We call subscapular bursa. Similarly, not always, sometimes posteriorly a pouch of synovial membrane comes out to produce another bursa, infraspinatus bursa. Finished. Detailing not required. Such নামগুলি জানবে। এই যে opening. Through this opening, a bursa communicates through the joint capsule. This is the picture of the shoulder joint. Actual picture. Next হচ্ছে glenohumeral ligament. Glenohumeral ligament is nothing but part of the capsule gets thickened in 3 areas anteriorly. Capsule is a simple capsule, but part of the capsule is thickened 1, 2, 3. এটা ক্যাপসুল, এই জায়গাটা একটু থিকেন্ড হয়ে গেল। Capsule is a simple capsular and this part of the capsule is thickened. We call it a ligament. কিছুই নয়। Capsule get thickened here. মানে একটু মোটা হয়ে গেছে ক্যাপসুলটা, আমরা একটা নাম দিয়ে দিলাম। এরকম anteriorly there are 3 thickenings, upper, middle and lower from the from the labrum কি এক্ষুনি আসছি, and attached to the humerus. We call it glenohumeral ligaments. Glenohumeral ligaments. কিছুই নয়। এটি বাইরে থেকে we cannot properly view this on the outside. If we cut the capsule, look from inside, then the thickening gets prominent. We can view it. Not very important ligament. Next, most important, one of the stability factor, glenoidal labrum. In recent state, মানে যখন লিভিং করছিল, there is a cartilaginous ring attached to the edge of the glenoid fossa. এই যে দেখো, which makes deepen the shallow glenoid fossa into a deeper one. চারপাশে একটা রিম দিয়ে দিয়েছে, বুঝতে পেরেছো? তাকে ফাইব্রোকার্টিলেজ, made up of a fibrocartilage. We call it glenoidal labrum. বাস ফিনিশড। বেশি পড়বে না এগুলি, জাস্ট নাম এক লাইন। নেক্সট, coracohumeral ligament. Obviously you can see it is also a thickening of the capsule from the coracoid process to the upper end of humerus. We call coracohumeral ligament. Finished. Transverse humeral ligament. This is the intertubercular sulcus. Through this tendon of the biceps coming out, and transversely there is a ligament is there. We call transverse humeral ligament. Finished. Detailing not required. Next, the most important. তাহলে এগুলি বলে দিয়েছি। So look, this is the glenohumeral ligament. এই যে এক একটা thickening, and this is the coracohumeral ligament. This is the coracohumeral ligament. This is the glenohumeral ligament. One superior glenohumeral ligament, middle glenohumeral ligament, lateral glenohumeral ligament. Just thickening of the capsule, and this is the coracohumeral ligament. And this is the glenoidal labrum. এইবারে যেটা বলেছিলাম, so there is an every chance of dislocation of the shoulder joint. Every যে movement করছি, as there is a cavity is shallow, humerus is larger, so there is a chance of dislocation. But আমাদের কি হচ্ছে dislocation? No. So there are some factors, some reasons by which the shoulder joint is not dislocated. What are the reasons? 1, 2, 3, 4, 5. The most important is the musculotendinous rotator cuff. Sits, মনে রাখবে। কি ব্যাপারটা আছে কি ছবি দেখছি? Yes. There are muscles around the joint. In the joint, surrounding the joint, there are muscles. Above, anteriorly and posteriorly, and inferiorly slightly away. Anteriorly, there is a big muscle. We call it subscapularis. মনে পড়ছে? Scapula, extensive origin, takes origin from here, inserted into the humerus, head of the humerus. Head কি বলছি? Tubercle of the humerus. তাহলে এই গেল subscapularis anteriorly. Above, there is a supraspinatus tendon. Supraspinatus muscle, a muscle. Or it takes origin from here. Supraspinatus muscle. So anteriorly there is a subscapularis. Superiorly there is a supraspinatus. Posteriorly, two muscles give support. Infraspinatus and teres minor. তাহলে কটা মাসল হলো? 4. কি করে মনে রাখবো? Sits, 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 subscapularis, supraspinatus, infraspinatus, teres minor, subscapularis. From here to here. Supraspinatus, back infraspinatus and teres minor, and anteriorly subscapularis. These 4 muscles surround the joint and attached to the joint capsule, makes extra protection of the capsule so that joint do not get dislocated. Not only that, they also support the movement of the abduction. I will come later on. কোন রিজনটা বাদ দিলাম? Superiorly supraspinatus, anteriorly subscapularis, posteriorly infraspinatus and teres minor. কোনটা বাদ দিলাম? সুপিরিয়র বললাম, অ্যান্টেরিয়র বললাম, পস্টেরিয়র বললাম, কোনটা বাদ দিয়েছি? ইনফেরিয়র. Inferiorly muscles are there but slightly away. Long head of triceps and teres major. So that, and they are not attached to the capsule. So dislocate, very important question, explain why. Which direction the dislocation of the shoulder joint is common? Inferior. Because anteriorly it is prevented by the subscapularis. Superiorly, supraspinatus tendon and also coracoacromial arch. Inferiorly and posteriorly, infraspinatus and teres minor. But inferiorly, it is less well supported. No direct muscle is support the capsule. There is a chance of inferior dislocation. এখানে বেরোতে পারে, চেষ্টা চলবে। They try to move anteriorly, but it is prevented. Try to move, especially in abduction, there is a chance of superior dislocation, but they are protected. Try to move posteriorly, infraspinatus teres minor protection. But inferiorly, they are not well protected, so there is a chance, not always, There are other factors also prevent the dislocation. I will come. So, most common site is the inferior dislocation. But inferior dislocation hole ki hobe? হাতটা উপরে উঠে থাকে সাধারণত তার জন্য মোটামুটি এটা আইদার অ্যান্টেরিয়র বা পস্টেরিয়র দিকে চলে যায় লেটার বাট অ্যানাটমিক্যালি আমি বলবো in which direction the dislocation is common inferior but as it is the unstable position later the head comes anterior or posterior to the glenoid cavity but initially there is an inferior dislocation তাহলে যদি কোশ্চেন করে which type of dislocation is common answer is the inferior dislocation but later as it is a unstable position later gradually the head comes either anteriorly or posterior to the shoulder joint but the answer first will be inferior dislocation মনে থাকবে এটা পরীক্ষায় inferior dislocation আর কি ফ্যাক্টর রয়েছে glenoidal labrum glenoidal labrum fibrocartilaginous ring which increases the depth of the fossa and also prevent the dislocation in all direction. Next, supraspinatus tendon. Capsule and coracohumeral ligament pull a supraspinatus tendon. Whenever there is a chance of dislocation inferiorly, supraspinatus tendon pull the head upwards. J inferior try to the joint the humerus is trying to do the inferior dislocation, supraspinatus tendon by its muscle action pull the head upwards. Coracohumeral ligament prevents inferior dislocation of the joint. So these are the factors. Next, long এবার খুব ভালো করে শোনো long head of biceps আগেই বলেছি coming from this long head of biceps এই যে গেছে so it also gives an extra protection to the upward dislocation of the shoulder joint so these are the factors which gives stability of the shoulder joint musculotendinous rotator cuff আর এই যে four muscles what we describe supraspinatus infraspinatus teres minor and subscapularis we call it rotator cuff muscle we call them together four muscles rotator cuff so what are the factors give stability of the shoulder joint musculotendinous rotator cuff shoulder joint a glenoidal labrum supraspinatus upper part of fibrous capsule and coracohumeral ligament long tendon of biceps and coracoacromial arch and long head of triceps and teres major give some protection inferiorly what are the bursae around the joint there are so many bursae but of which three you just remember anteriorly there is an subscapular bursa which communicates with the joint cavity through an opening of the capsule I have already told you inferiorly posteriorly there is an occasionally not all persons there is an infraspinatus bursa between the infraspinatus muscle and the capsule which may or may not communicate with the joint cavity the last but not the least subacromial bursa what I have told you under the coracoacromial arch there is an supraspinatus tendon in between the supraspinatus and coracoacromial arch there is an bursa we call subacromial bursa as it is below the acromion process it is a coracoacromial arch coracoacromial ligament here and supraspinatus tendon is here muscle and it is the coracoacromial arch a bursa a subacromial bursa right and also a synovial sheath give bursa like projection along the tendon of the long head of biceps যেটা আমি বলেছিলাম it gives a slip to cover the long head কি beautiful picture দেখো it gives the blue is actually the synovial membrane covering the inside of the joint cavity and comes out through the opening to form a bursa here to form a bursa here posteriorly we cannot see, and also a sleeve around the long tendon of bicep. And subacromial bursa never communicate with the joint cavity. So subacromial bursa never has got a communication, never joins the joint cavity.